Hello everyone and welcome back. Slightly different one for you today. This is by viewer request. A few of you asked about Thermafil Retreat. So as you can see, that is a very shoddy looking obturation there. Poor kiddo had a decent amount of swelling as well on this one. And you'll see the cone beam here, missed MB2, large infection, blown out sinus, a lot going on this poor little guy. So what we're going to do is start off like we do every case by just adjusting that bite, getting rid of any excursive interferences, and then moving on with our access through the crown itself. Something a little bit different here is I'm not going to make any cuts. You'll notice there are a few things here and there. It's just the I did stabilize the footage so that it's actually watchable and you guys won't get car sick watching it. But pretty much we're doing a full start to finish without any cuts. I mean, minus the month for calcium hydroxide to show you how this works. Dropping through that zirconia crown there. One trick is as soon as you drop through the zirconia, switch to a larger burr and do an up and down motion. That allows a larger portion of the diamonds to hit the zirconia as well as cool off in between. So you really just want to use that round burr to just pop through the occlusal and then use a long tapered diamond. I either use the workhorse or the prep burr to do the rest of it, just so that you don't have to use your expensive diamonds. These are a lot more affordable and they work a lot better too. You can see we've done most of the access and still fine. I'll be using it here in a little bit. So we can see the guide to purchase starting to show through at this point. I'm going to do a little bit more work here. I suspected this was a Thermafil just based on the appearance on the x-ray as well as the cone beam. And with this sort of thing, you want to make sure you remove the composite on top of those carriers. Oftentimes when the general dentists leave these, they leave kind of a mess inside the chamber, and you can see I'm cleaning up some of that gutta percha right now. And if the composite is blocking the path of exit of the carrier, you're not going to be able to get those out. And so that's one of the considerations here is make sure you remove the composite. You'll notice that my access did go up onto that MB cusp. Oftentimes you'll find during retreats or even sometimes during initial treatments that in order to get access to the cusp or to the canals, you actually have to go into the cusp a little bit. That's not really a big deal with our materials that we have now. They're modern enough. They're going to work out well. So as you can see, I'm kind of looking at everything and starting the process here with using the alpha to remove that gutta percha and start to create space. And when you're doing thermafils, there's 100 different ways to try to get them out. This just works best in my hand. I like to use the alpha to remove the bulk of the gutta percha. Just use it any heated tip pretty much. And that will start to expose the area and create space for your F1 or whatever file you're going to use. In this case, I'm going to use the F1 spinning at 550 like normal. And you can see the palatal was so poorly obturated, I actually dropped pretty much to length immediately. Working length on this one was about 21, give or take. And so you can see I've already dropped down mostly to the stopper. MB or distal buckle there, you can see we actually pop the carrier out right away. So sometimes you get lucky doing this technique, spin it fast and brush. And oftentimes because these are such active flutes, they will grab the carrier and just rip it out in one piece, which makes your life really, really easy. Going down the MBs now, you can see they kind of sort of got MB2. That's me getting into MB2 right there. So this is a case where they did for sure join up, but because there was some untreated anatomy, I'm not sure if that caused the failure. You can see how the fin as I'm cleaning that out as well. So not sure if the MB2 caused the failure, the poor obturation caused the failure. Maybe they didn't clean everything out enough for the first time. I don't know. This wasn't done by his general dentist. He got it done in California somewhere. So unsure who actually did this treatment to begin with for him. At this point, going to go ahead and rinse everything out to start to kind of get a clear access of what we need to. You'll notice I only have one carrier out so far. The one in the distal buckle popped out very readily, and so we're going to have to go after those remaining two. My preferred method is using large headstrums. So I keep up to size, I think I have 15 through 50 in the room. I do have a pack of larger ones. I don't have to pull those out too often, thankfully. But in general, that's all you're going to need for this sort of thing. So got that cleaned out, and now we're going to come in. I'm actually going to use the SX burr here because it is even more aggressive up top. And this was pretty much a pro taper shape to begin with. Whoever did the root canal initially definitely removed a lot more tooth structure than I would like. But the kid was also 18, so he had pretty large canals to begin with. So another trick here is you can use the SX and brush it. You can see I'm going pretty hard, either mesial, distal, buccolingual, depending on which angle I can get it in there. And because, once again, it has very aggressive flutes, it will often grab the gutta percha and rip everything out, which is exactly what you want. You can see just how much loose gutta percha we're removing just with rinsing with Triton here, just to get that little bit out. I already have that much out, which is pretty cool. So at this point, we're going to go ahead and try to remove just a little bit more, rinse it out with some water so I can see what we're going at. You can see the carrier still inside the MB, and there's a little bit of isthmus of gutta percha that we're going to need to remove between the distal buccal and the palatal. Once again, those little slight changes in zooming, that is from the stabilization process. So I promise none of these are cuts. This is the actual time it takes. And you can see here, trying to get that carrier out, and one of the problems here is sometimes it's, actually no, that one came out, it's the other one I have to do it for. So you can see where I've removed on the plastic itself, that there's that space there. Whether or not that's from the F1 or from the headstrom, I'm not sure. I'm just happy we got this bad boy out. And then same thing here, working up. And when you aren't able to get it in, you'll see I'm actually screwing this in. So it's a righty-tighty situation here. Move down a little bit and then slowly pull out. And so you'll feel it almost kind of pop. The idea here, there you go, and out it comes. So 1, 2, and 3, not too bad to get all those out in, just under 6 minutes, give or take. Not too bad to remove everything. Now, there is still a lot of gutta percha left in both the distal buccal and the palatal, so I'm going to show you how we get that out here in a second, but we're going to be getting length and moving from there. Now, with that headstrom technique, you sometimes have to use 2, sometimes you can use 1. Really, the idea is you want to use the fact that the plastic is going to be a lot softer than the dentinal walls, so that when you are screwing the headstrom into the carrier, instead of it binding into the dentin, it binds into the plastic, and then it's a lot easier to pull out. So that's kind of the key here. You can see there's still a little bit of gutta percha. We're going to get the rest of that out here with the F1. Actually, sneak peek, we don't get all of it out. I'll show you at the end what I'm talking about. But everything else looks pretty straightforward. So here's the working length, and when we're doing working length, it's pretty straightforward. I left this in just for, to show from start to finish kind of what it looks like. You can see they had me the wrong forceps there. Those are the file forceps, not the actual locking forceps. So we're going to go back in, and in this case, when it's so large, what I end up doing is usually just locking it in place and measuring it. So you saw palatal length there was 21. Slight bend here. On the distal buccal, this one is kind of interesting. I was able to get patent, but when you look at the calcium hydroxide shot, it almost looks like there's still some gutta percha inside there. I don't think it's part of the carrier because I looked at the carriers after and they are all intact. So I think there was some gutta percha that we weren't able to get all the way out. And when you look at the final, it might still be there. It might be stuck kind of in a ledged area or in I'm not really sure what exactly happened there, but we were able to bypass it. Patient was feeling great, so I did obturate where we are. You can see here, this is kind of how I do the working length. In this case, we're having a little bit of trouble with those MBs, so going to pull that out, coming in at right around that 20.5, and then looking at our MB2. Still, I can feel that there's some gutta percha kind of blocking me from going down. Sometimes you can get around it, sometimes you can't, but that's what I'm doing there. Kind of that, sometimes you do a watch winding. Most of the time I just kind of do a light, gentle screwing in to the right. You gotta be careful with that. As you can see, that bent that file pretty badly. So we've ran into gutta percha on the MB, and so I'm going to show you how we handle that. The final shape for these is going to be an F1. I guarantee whoever the dentist was who did this initially took these to a larger size. So I'm going to be just using the F1 just to remove the bulk of the gutta percha. And I'm not really concerned about the whole, scraping all the walls thing, because I'm going to be using calcium hydroxide. And when the patient returns, we're going to find out whether or not he's symptomatic by whether or not we can dry the case and whether or not he's still swollen. So that's what we're working on here. And it felt a little funky. One other cool trick, you can actually use rotary files to get length, and you can see me spinning it there. That allows you to be pretty accurate in how far the length is, and then it gets you an idea, look up at the side, and so we're right at 21. So happy with that length as well. You can see I'm hitting a little bit there in the distal buccal. It kind of is just like there's stuff in the isthmus. There's just kind of stuff inside there. And that's one of the hallmark things with all these Thermafil cases is there's so much gutta percha everywhere. It's because when you use these, if you're using them, It's kind of expensive. It's probably not the best obturation method out there, would be my recommendation. Learn, if you want to get into endo, I really wouldn't recommend using this. However, if you are going to use it, one tip is to take the coronal aspect of gutta percha. You really only need maybe that apical third of gutta percha on the carrier itself, and just kind of flick that off. That way you don't have as much to clean up when you're done. There's a couple different ways to clean up the chamber. Most of the time they tell you to use like an endo Z burr so it doesn't cut the shape of the pulpal floor, and you can remove everything. That works pretty well. Diamonds work well as well as that. So it's kind of up to you. But if you are going to use it, that's kind of a tip, is just to remove that top portion of the gutta percha. There's nothing wrong with Thermafil inherently. It's just if it's used incorrectly, it's going to fail, because you cannot have plastic be the only thing sealing. And you can see on both of those pieces kind of left behind, there is no gutta percha at the apical part, which tells me that only the plastic carrier was actually sealing that area. Little bit of drainage from the palatal, which to be expected given the size of that sinus. Not as much from the MB or DB, but still we're going to go ahead and medicate this. I don't want to have any, with an infection this large, with a, acute apical abscess. Poor dude was pretty swollen. They drive from a few hours away as well. So want to make sure that we're not wasting their time by finishing the case today. So going to go in, you can see I'm getting most of these paper points pretty stinking dry, all things considered. There's our MB1 and 2. You can see they're kind of just a cute little figure of 8, but don't think that it's not important to still clean that area out. What caused the failure here? More than likely the obturation and all the other nonsense. But if you don't clean out those MB2s, I've seen many cases fail with just that small little thing there. I just redo the MBs and the case is fine. So do not leave untreated. Anatomy is the best advice I can give you. That is the number one reason I have to redo root canals, and upper molars are by far the number one tooth that I have to do. So if you're trying to learn how to do maxillary molars, learn how to find MB2. It's very, 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 very difficult to do with loupes. I did it a little bit when I was moonlighting and couldn't have a microscope, and I would say I found maybe 50% of them. So even with having to find them all the time in residency, it was still very, very difficult to actually locate them without the help of a microscope. So I would not recommend doing any maxillary molars, whether first or second, without a dental microscope at this point. And at that point, we're pretty much done. So one thing I did want to do is smooth off that area where the cusps are, because cavit does wear down over time, and if we leave those areas sharp, it's going to be really annoying to his tongue and cheek. So it doesn't take that much to go in, just kind of buff off any right angles using the barrel burr, and that just makes sure the patient doesn't have a bad time.
You're gonna have a bad time.
Pretty much. So what we're going to do here is cavit. Works well. They're coming back in a month anyway, so not a big deal for them. And we will show calcium hydroxide shot here in just a second. And when we look at the calcium hydroxide shot, I mostly want you to look at the distal buccal. You can look at the other two. You can hit pause. You can do whatever you want. But when you look at that, it looks like there's still a piece of gutta percha, maybe a little bit in the MB as well, and maybe a little bit in the palatal. There's a lot of gutta percha in these cases. So what we're going to do is re-access, make sure we can clean everything out using the 20K file. And as long as we're patent, we can pretty much seal this up without any worries here. So once again, when I go back through to remove cavit, I'm usually going to use that workhorse burr. Ooh, look at me. Twice I've said horse without a problem. Just because it is a much... sorry, that's actually a prep burr, so I've just screwed all that up. Anyway. I use the larger diamond there because it's faster, easier to remove everything. This dentist likes to see his patients back for the restorative, so I won't be doing the restorative, so I'm not as concerned about removing all of the cavit because we're just going to be putting some more cavit back inside there. You can see a little bit of the... I'm both removing gutta percha here as well as the piece of the sponge that's kind of stuck inside there. So Endo Explorers are just a nice do-all instrument for you there. Making sure that isthmus between the DB and palatal, if they join, there's always going to be junk stuck inside there. And it's very difficult to clean all of that out effectively. That's where like a laser or a gentle wave would be a nice toy. And what we're doing here is making sure we're patent. Going back down, you can see even that 20K file is able to remove a little bit of that gutta percha. And usually once you've had the calcium hydroxide inside there, it loosens up any remaining gutta percha pieces and makes them very, very easy to remove. So recapitulating here, making sure that everything's nice and smooth all the way to the apex, and that's why I like that 20K file, just to ensure. So you can see here, we're not quite all the way down on that 1 MB, so a little bit of hand filing just to make sure, and you should see a drop here in just a second. And that just ensures that everything's all the way clean to the bottom. So let's go ahead and do our final rinse here. So, MB2 didn't seem to drop all the way, but as they joined, I think I was fine. And you could see before I moved the mirror just how much gutta percha is coming out. Oftentimes just loosening it up inside there using a K file is enough to get most of this junk out of there. It's a really cool technique. By using the calcium hydroxide, it seems to loosen the gutta percha a little bit better. This is an older video. I forgot that I don't know why I forgot to post this one, but I know that someone had asked for a Thermafil video, and I was like, oh, I thought I had a Thermafil video out, and it's supposed to be this one. So this was done back in, I think, July this year. So this is before we had all the new toys, and by new toys I mean like 2 new things that I've got since then. So you're looking at a blast from the past right here. What we are doing right here is, I'm not sure actually. I told you I'm not making any cuts. You get to have the full in-person experience, and I'm gonna let you know here just in a second what we're gonna do. I think we ran out of EDTA, so that's what that is. That's all it takes. Sometimes you never know. And you can see even with doing all that rinsing already with the bleach, there's still a few little pieces of gutta percha coming out. All of the studies have shown, especially if you use SEMs, that there's always going to be gutta percha left. So the goal is to get out as much as reasonably possible. You don't want to destroy the tooth, obviously. The fact that he came back, he wasn't swollen, feeling great, could chew on it, there's no drainage, that makes me highly comfortable that we should be fine finishing it. I'm still going to remove the gutta percha just to make things look as clean as possible, but in this case, he's going to be totally fine. Do our final rinse here now with a little bit of isopropyl alcohol, and you can see nothing's coming up at this point, so I'm very pleased. We are ready to seal everything up. The reason we use the isopropyl alcohol, I think I've talked about this in the past, but it's been a minute, is because it evaporates very quickly and it's very easy to dry. So I can use the little micro suction that's on my ASI cart to remove the bulk of it, and then I'll usually go in with the air-only Stropco, just lightly hit it, and most of the time that causes everything to evaporate. That's what you're seeing right there. Real quick, the pressure on that is very low as well, so I'm not worried about having embolism or any issues like that. You can turn it up and down depending on your ASI cart. If you have a different system, they should all allow you to turn them up and down. So paper points now just to make sure everything's nice and dry, and clean everything and get ready for the squirt technique here. So this is all real time. Like I said, no cuts or anything, so you get the idea of kind of how long it takes. Once again, those cuts there, I did have to make a few snips, otherwise it wouldn't do the stabilization. It gets upset when it has to stabilize like a 20-minute video. So that's what those cuts are here or there. It just allows the computer to actually stabilize the video, so it's not too bad. But there you can see MB1 and 2. Just did a couple quick pictures there, but I'm not gonna, you know what they look like, so no need to post those. And gonna do the obturation here. So at this point we got everything nice and dry. Next step is to come in with the AH+, and I just place that on the paper point, kind of to length roughly, and I'm going to make sure we carry it to length using the 20K file. So that's what you're going to see me do here. Actually, we have one more AH+ to do for the big palatal. And that's about the amount that you need, maybe a little less. I can usually get about 2 canals per paper point, give or take, before we start to run out. And as you can see, we're now able to drop all the way down. All those were patent very easily to the bottom, so that final rinse process did remove any gutta percha that may have been in the way, which is nice. So I'm going to do the squirt technique for this, and with this one, I'm not pushing as hard as I normally would just because of how large the infection was inside here. So, you know, the technique is so varying. My advice, if you want to learn how to do the squirt technique, I'm still going to order those plastic blocks to show you, but if you want to do them, find a pretty straightforward premolar, shape it to, you know, like a smaller-ish size, and try it. As long as it's straight, it's not hard to retreat it. If you have to, you know, it doesn't take that long to quick rip out gutta percha if you're not happy with the fill. But that's really the best way to learn how to do it, is to start. You got to start somewhere. Those cases seem to be a little more predictable in my hands, and so that's where I'd recommend starting. You know, a large tooth like this with a large infection, you do run the risk of setting stuff out, especially with the sinus involvement. So you do have to be careful here of any structures. Same thing if you're working down on a mandibular molar near the IA or a premolar near the mental. You just got to be careful in those areas and, you know, use your judgment. But as you practice and do more and more, that's just why it's called practice, you'll kind of learn the pressure that you need. And that's why I like using the handheld one, is it's a little bit easier to control that pressure. So at this point, obturation's done. That's really the big benefit of the squirt technique. Besides, I think it looks prettier. It gets hot gutta percha all the way to the apex. It can fill in voids better than anything else. And it's also pretty darn quick because you don't have to worry about, cutting cones and doing everything. You let the tooth pretty much create a custom size. Removing that AH plus there using the isopropyl alcohol. I'm not sure what the delay was here. Oh, we didn't have a cotton pellet. So cotton pellet just to remove any excess. That's what's going on, just to clean everything out. And then we will get ready to do the PACMAC. And pretty much we're almost done here. So this one, like I said, not doing the restorative here. So we're going to come in with the PACMAC, just hit all of these after we rinse everything out. The other nice part about, one thing I forget to always mention with the PACMAC is it works better if the gutta percha has cooled. And so that's why I like using the isopropyl alcohol as well as the rinse beforehand, because it cools off that gutta percha and makes it a lot easier to use that PACMAC. What we're doing right now is I'm putting the PACMAC on the drill. That's about how long it takes. And as you can see, just taking it down about halfway. You don't have to, on a case like this where it's pretty large, I did, because of the isthmuses, or isthmi, I think we looked this up. I think it's actually both. Anyway, because of all the little intricacies between the two teeth, between the canals, I do want to use the PACMAC just to make sure we get a nice solid obturation, but I'm not going to be going excessively. And then we'll take a check film after this, make sure things look great. The assistant will temporize it and we will call it a day. So pretty straightforward here. This is the other thing I do love about those B&L condensers, is that back end does have a right angle. So you can see I wasn't happy. There's a little excess gutta percha on the palatal, and I was able to just use that right end to kind of push off and almost cut the gutta percha so it's nice and flat. So there are our two MBs looking nice and solid there. And there's our distal buccal and our palatal. So did take some quick pictures there, but that's what the final looks like. Did we push it on the MB? It's up to you. That could be calcium hydroxide. It could be something else, but I am pleased with how everything turned out. You can see on the distal buccal, it does look like there's a little bit of excess gutta percha there. It's not the carrier. So I think what may have happened here is when they did the initial treatment, they kind of ledged that distal buccal and there's gutta percha stuck inside there. Now, I could have opened this up to a much larger size, but given his age, I want to be as conservative as possible. So thought this would be a good one for all of you. If you have any questions, let me know if you like this format where we kind of show everything from start to finish, including the awkward pauses. For me, I kind of like things to be a little more succinct, but that is kind of your total time. So roughly about 20 minutes, start to finish. Obviously, there's a month in between, but hopefully that was an interesting video. If you have any questions, comments, please drop it below. Otherwise, like and subscribe, and thank you so much for watching as always, and I will talk to you next time.